Hey everyone, welcome back to my channel, and if you're new here, I am Adriaan and I interview the brightest minds of physical therapy. So if you want to increase your knowledge, start right now by subscribing to the channel, clicking on the bell so you don't miss anything, give us a thumbs up and share with your friends. Today, our guest is Jenet Delong, and she's going to talk about empowering patients with persistent pain. Jenet has been a PT for over 39 years, is a licensed social worker, and a nationally board-certified health and wellness coach. Jenet is also a research associate for Prevention Insights at Indiana University. I hope you enjoy the show. Hi, Jenet. Welcome to PT Pro Talk. How are you today?
Hi, Mariana. Very good. How are you doing?
I'm doing well and excited to talk about our topic today. So before we jump right in, just tell us a little bit about yourself, your career. How did you get to where you are right now?
Well, I don't know how much you want, but I, so I've been a physical therapist for about 39 years, and
Oh, wow.
yeah, and have, as far as I recall, generally seen people with persistent pain, even as a student. I've seen a lot of different people, done almost every kind of work you can as a PT, and have gained. Actually, when I got my education, it was a bachelor's degree, but the master's degree was coming out, so I went right back and got that. And then when the DPT came out, I got that as well because I like to keep learning. And worked mostly for hospital, mostly one hospital, a couple of them, and have been a manual therapist. I'll sort of give you a chronological kind of thing. I've always been a manual therapist, and I do have the MDT certification as well.
Oh, that's cool.
Sure. And though, early on, I love manual therapy, but early on, working with people, especially who'd had pain for people who have had pain for a while, I found they weren't doing anything on their own. They were just coming in and they were getting better, but they weren't making any changes, doing any exercises. So I thought, well, I'm doing all the work, let's change. And I would give exercises first, and have them change the way they function, educate them about that. And they got better faster, actually, and started doing things, but they would still stop doing their exercises when they left me, because they would come back. We build a relationship. They would come back, and some of them would bring a whole notebook of the same exercises that I had given them before. And so it was so interesting, and it made me think, okay, when people change their behavior, they get better, but behavior change is hard. So I went and got a couple of health and wellness coaching certifications, like life coaching, a basic and professional, and had a different kind of relationship and a different kind of conversation with my patients. Around this time, I started my own practice as well. And so it made a big difference. People were able to be more empowered and start to make more changes on their own, and more sustainable changes.
So how do you feel like this coaching changed the way you talk to patients?
Oh, it made a dramatic change. And I would encourage all PTs to learn about this. It made me appreciate that, number one, this is about behavior change. And so there's a trans theoretical model of change. I don't know if you're familiar with that, but we all that's where everyone is in a different stage of change for all kinds of things that we do. And so it goes from pre-contemplation, where I'm not even aware of a problem, to contemplation, where I'm thinking about it, and then preparation, when I've decided, okay, I'm going to get ready, and then action, about a month of making some changes. And then there's maintenance, which can go on for 6 months or so. And so we as PTs see that our patients are or are not making the changes that would help them to get better. And we have a tendency to want to blame them. And so the reason I mentioned the trans-theoretical model of change is because we all, including us PTs, have things that are difficult for us to change. So it's a human trait. It's not just our patients. And so for me to be, not be a hypocrite, then I need to recognize that change is hard. And so I need to have empathy with that patient and just try to understand their situation. So the conversation is all about asking open-ended questions and listening deeply to what they're saying. And I think PTs are good at developing relationships. And there's a deep listening that's really important, and sort of a reflecting back of what the patient says. That's helpful for the patient to hear their own words and then come up with some of their own answers. We PTs like to help people solve problems, but very often the patients have the answers within themselves. And so our conversation is about helping them discover that.
So you are just trying to make them see and look to their problems and help them in that way, because it's like you're doing counseling. When you start talking, you already see, you realize what you're saying, and the answer is usually you already know it. You just need some help to put it out and realize that. So that's interesting.
Yes. And it's funny because I've heard PTs and even other support staff say, well, we're not counselors, and that's true. And yet this isn't a counseling conversation. It can be, but the difference is not the conversation itself, but whether we would continue to have that conversation if somebody were stuck in a cycle. But this is a way of being with people and a way of having a conversation to collaborate.
And sometimes we just giving them some space to talk about their problems and paying attention and listening already makes a big change. Even if you're not doing anything physically, they just feel heard, and that helps them in the trust you and really be willing to put in the work to try to improve. So I think that's a big part of the treatment as well.
Exactly. I teach motivational interviewing as part of my work that I'm doing now, in addition to teaching college students in a couple of places.
So what is this motivational interviewing?
That is, again, a way of being with people where we don't come in as an expert. We come in and actually put our expert hat aside and really show empathy and listen and have compassion on someone and accept them where they are, and really lose any judgment, which is a hard thing for humans to do. And then have this collaborative conversation, again, really kind of like the coaching, where we believe in the patient to have the answers, and we ask these questions and we affirm their efforts. We look for outcomes, and yet we need to have process goals and affirm the patient's efforts and strengths that they're showing in their quest, and giving these reflections, and then really give the believe that the patient is an expert in their own lives, and so we need to honor that and let them come up with their own goals, and we guide them rather than wag our finger and tell them what to do.
Yeah, so I think that makes a big difference on the treatment as well, because sometimes we just want to jump in and say what we think that they need and why we think it's important for them, rather than let them speak about what they want, right?
Yes, exactly. Yes, you know all about this. I think.
I think you start to learn over time just with your experience with patients, and then I see that you did a lot of training and really like that part of the treatment of improving our relationship and trying to help uh, patients to solve their pains, because we know that as you mentioned before, that you work a lot with persistent pain. We know
Mm-hmm.
that sometimes it's not just physical, it goes beyond that, so we need to give them support in the other problems that they are facing, and sometimes it's just the way we approach, the way we talk, the way we ask and listen to them, right?
Yes, absolutely. You know, there's a time and a place for education because people do need to learn, and yet we won't even know. I'll actually address what you're talking about, but also when we do give education, we don't even know what they're ready for or what they already know until we've really listened and had that conversation with them.
And I was going to ask you that you said that you did the coaching and then you were talking about your career. I was just going to go back to let you finish the line of thought that I know you did more other than after the coaching. So, how was the progression of your career after that?
Well, it's funny because I love working with people and I love to do things that work. I do love a challenge, and yet um, when things don't work, I just sort of stop doing them because they don't make any sense anymore. And so the coaching really did help, and does help with patients, and helping them to change behavior. And somewhere along the line, I realized that a lot of people's persistent pain comes from trauma that they've had in their lives. Whether it could be abuse, emotional, physical, or sexual abuse, especially as a child, um, or it could be neglect. It could be someone in the household um, who has uh, been incarcerated or with a substance use disorder. But the things that happen to us as children, in fact, these are called adverse childhood experiences, affect both our mental and physical health later. And so I realized that I could help people as much as I wanted to with manual therapy and teaching them how to move differently, and do some exercises if they were willing to do that. And yet they would never get better because their pain was from a different source. It was through their nervous system, through their emotions, and they needed to process that trauma. And so that was beyond my scope of care. And so I both would refer people to a counselor, and I had grown so fond of doing the coaching that I decided to go and get another degree myself, so that I could do counseling, because that's rewarding as well. And so I looked at psychology, like being a psychologist or just a straight counselor, and I chose a Master of Social Work. Eventually, I will end up as a licensed clinical social worker. I'm a licensed social worker now. because of the human rights aspect and the social justice aspect. Just to explain about that, when people don't have a home, when they aren't safe, they don't have access to health care, they don't have enough food, there's just so much scarcity for them, they are more likely to have persistent pain as well. And so I wanted to get a well-rounded education about that.
That's awesome. And I know that you have all these like backgrounds, coaching, licensed social worker, to try to help the patients in many different ways that sometimes we can't just as physical therapists, right? So from your background as a licensed social worker, what did you learn that you think it's important for PTs to use that to try to help their patients in different ways, either referring, identifying signs of abuse, or how can we use that in simple ways on our day-to-day practice to help these patients?
That's a great question. I think that it starts with educating ourselves so that we understand, for instance, the adverse childhood experiences, the 10 things that can happen to people as a child that affect them later. And then I think it's probably the most important thing is to create a safe relationship and a safe space for that patient, because they a lot of persistent pain can be there because of a past threat. And although and I think that other people on your podcast have spoken about this, but even if the threat is no longer present, then that person's nervous system still sees that. And until that's processed in a very safe space, it's not going to go away. And so what we see as maybe resistance or, odd behavior isn't odd at all when we consider what that person's been through. And that's another thing, is a willingness to have uncomfortable conversation with our patients. I remember, several years ago, we, in our hospital clinic at that point, decided it was important to ask the patients if they had any mental health issues. I guess that was the main thing. And the therapists were reluctant to do that because, we don't have training in that realm. And I didn't either, except for the coaching. But I found that patients were very willing to talk about that. I think they were reassured that someone cared and would ask. And it didn't go on and on like you might imagine, because I know we're busy. And so you get a talker and that eats up your time. So for PTs, I think that willingness to just ask and be open. And if someone doesn't share right then, if they see that we're truly creating a safe space for them, then they might share later. And then we can help them understand that they may need another kind of therapist. They may need to see someone about their trauma or whatever has happened to them.
I remember that in one of the clinics I used to work on the farms, they had a question. Have you have depression or anxiety feelings? Or have you ever had like suicidal, how you say it, suicidal thoughts?
Mm-hmm.
And then many of them, for my surprise, would say yes and would click the box. And
Yes.
they knew that we would ask them, because then what do? You said yes. So I have to talk about it. I have to call your doctor and let them know, or try to, and I noticed that they wanted someone to help them or get a counselor sometimes that they couldn't have, or just try to make things easier for them. They wanted some help. So that was extra surprise, the number of people that check the box when you're
Yeah.
doing assessments.
Mm-hmm.
So, but then I think I understand why PTs get uncomfortable, because I would get uncomfortable. I don't know, okay, what do I do now? I just call the doctor, like, what can I do? I'm just going to refer the patient.
Right, right. And that is so true. We don't have, as part of our formal training, we don't know what to do, except that, well, number one, it goes back to, unless we do something about this with this person, we won't get any further with our own treatment with them, because we are seeing these red flags and we need to address them. And of course, how often does this come at the end of the day, or when you were going to try to get out early, or, the logistics of our own work life? But I think it's important for us to get just the continuing education to know, there is I'm not going to remember the name of it, just a really quick assessment, though, that we can use to ask the patients, okay, you checked yes on the I am having suicidal feelings or thoughts. Is this something, are you considering, the important questions are, I guess they're all important, but the important thing for us to know is, are you considering really doing this, and do you have a plan? And if they say yes to that, then we do need, we need to have a call to, it could be to a family member, actually. But, this is a person in our clinic, and this is what they have, told us. And, it would be easier if we never asked the question in the first place, but we can't, as a society, even do that anymore. We have to embrace mental health that goes right along with physical health. And so we're one whole person, because the mental health issues do coincide with, they're not only caused by persistent pain, but they are a cause of pain as well. So this is coming full circle here. But I do think that we do need to educate ourselves. I think clinics need to bring people in so we understand about creating the safe space, and then asking the questions, and then the basics of what we would need to do.
And when you say create a safe space, what does it mean? Why would you consider creating a safe space?
So often, people with persistent pain have this because, again, they have the fear that's been associated with a previous trauma or abuse. They also, so we need to create a safe space so we develop a relationship of trust, and they know that we are not going to ask anything of them that they don't approve of, and that we won't do anything that will create harm. Also, people with persistent pain have been dismissed by all kinds of providers in their lives. And we don't want to, and that's very harmful. And so they're often going to come to us with that same mistrust, because why would we be any different? So we have some hurdles to overcome to even gain their trust in the first place. And so they're not really going to work with us and be honest with us unless we do create that same space and demonstrate that empathy.
And would you say that we would create this space by listening to them, let them talk, trying to accommodate their feelings, and trying to educate them with talk about their pain, and just giving more attention and really listening to them? So just consider what they're saying in that sense.
Yes, very much about listening. And even with the education, I really like for people to understand what's happening with their body and also what might be happening in their brain and their nervous system. And I point to my amygdala and my explain about the limbic system, even if they haven't told me about any past trauma or abuse. I still want them to know that fear, that every bit of incoming stimuli goes to our amygdala, our limbic system, and which compares the new stimuli with that person's history. So, and this even, and so that they understand that not every fear that they have is valid, because we have fears and thoughts. That's a human thing, and I think 85% of our thoughts are negative, just as being a human. And
That's
so
a lot.
it is. It's amazing. Um, and very often they're recurring negative thoughts. And that includes those fears. And so they become so real to that person. And so I like them to learn about mindfulness as well, so that they examine those thoughts and kind of look for, do they make sense or not? And notice, being mindful about the pain that they have, what's really there, what's not there, and what makes it better or worse, to help them to start to, again, be a little bit skeptical of those thoughts and fears and see if what they're feeling in their body matches their fears.
Yeah. And I know you mentioned before the adverse childhood experience.
Mm-hmm.
So, would you just tell us a little bit about what are these experiences and how can we identify that?
Yes. So there are 10 instances of, um, these adverse experiences that can happen to a child. And it's between ages 0 and 18. And they are in the categories of abuse and neglect and household dysfunction. So other people in the household, their environment. And again, it was physical and emotional and sexual abuse that happens, and it's more common than we think. It's very sad, and so actually we need to think about how to help that situation too. I'm always thinking about prevention, um, and that's another piece of my career. But so neglect can be physical neglect of the child's actual needs, or emotional neglect. So they just don't get what they need emotionally, that support. And then household dysfunction is where the child witnesses the mother being abused or actually treated violently, divorce, substance use by someone in the home, a relative who is in jail or prison, and then someone who has a mental health issue in the home. So those are 10 items, and there's actually there's an ACE score. So it's really just a simple questionnaire. Have you had these things happen to you in your childhood? And if someone has 4 or more items that did happen to them, they're much more likely to have both physical problems and lifestyle changes, like unhealthy lifestyle choices like smoking or substance use disorder, um, and also mental health issues. But it's funny because but things that we consider heart issues and certain types of cancers, things that we think are just from physical problems, can come about from these emotional and abuse situations.
Oh, absolutely.
So just asking, oh, sorry, you asked how can we find out? So just actually throwing that assessment into the intake, there's a lot of paperwork. I'm always apologizing for that, but for the patient to do. But
so as a PT, do you use that intake form on your assessment?
No, I'm more interested in. I will probably add it to a conversation. As I move forward, though, and also my practice is sort of an integrated practice. So I said no, but as I move forward and bring my practice to a full integration, yes, I probably will ask that because it's just an easier way for people to see and do that.
And what are the signs that make you think about screening them for these events? To see, because you're not gonna just go and ask everybody about everything. So you probably have, I would imagine, some type of signs that you would think about screening for that situation to try to refer them. Or
if someone, well, I was going to say, if someone tells me they have depression or anxiety, then that is not a reason for me to refer them to someone necessarily, because people function quite well with depression and anxiety with support. But if they say that, then I'm going to ask about that. Often I will, just as I'm explaining about what we're going to do, I just mention the effect of our emotions and our fear and any past trauma on the body, and that some persistent pain comes from anxiety, and that some persistent pain comes from major depression disorder. That's well documented, I think, in the literature. And so I try to keep, just in a business-like way, mention those things, just matter of fact. So it's not, it's just more about, this is common knowledge, and then I've given them that information, and it's theirs to do with what they want. If they want to disclose more information to me, they can, but I'm not, getting in their face and asking them. And often people will tell me about something, but they'll say, but I've got a therapist, or I don't want to work on that, right now. So
you are
it's
more
really,
like give the opportunity, right? You give them the opportunity to talk about you open that space. If they want to mention or talk more than they
yes,
can, or if they don't feel ready, maybe later they will do something or look for someone. You're just
yes,
trying to give them the information.
yes, yes. Yeah, and that is part of that trusting relationship, and really letting them, lead with my guidance, which is a really different way of going about patient care than what we usually do. I do want to mention that it's interesting. Several patients, and one in particular always comes to my mind, have memories of abuse, maybe in their 40s. It's like they just start remembering things that they've just shut out. Their brain. We have a wonderful nervous system, and we disassociate from things that are too harmful or too much for us to bear. And so I might have had some coaching, but I didn't have a lot at that point. But this one person in particular, she started remembering sexual abuse as a child, and she did get some therapy, and we worked on the pain, but she kept trying to make her physical pain be the actual problem. She didn't understand that it was a result of that abuse. And so she was not successful. Most people end up understanding and doing well, and that one person. So she's a very vivid memory for me. And it's not uncommon.
Yeah. And I think that if we provide them education about mental health, if we have the education to provide them, at least I think we are doing our part, because we can just go so far because it's not our role. But I think we play a part on the educating them and giving them the ability or the tools to help them move forward with that, to help our treatment be successful,
Yes, yes,
right?
yes. Then when we can collaborate with another provider who's taking care of those needs, then we're all successful. Um, I think it's important for us to have a network of people that we feel comfortable referring our patients to, where we can give a warm handoff. We can call with them or while they're there, if that's what they'd like, or maybe give them a list of mental health providers.
Yes, because we know that we can go so far, and some clients like that patients, they're not going to get better, and we can do what we can do. So,
Exactly. Yeah. What we are doing, we can be doing wonderful work. And yet if the pain is from a different source, then, we're not we're not accessing the part of them that needs to be helped.
yeah. And so before I transition to our final questions, do you want to add anything else? I know with your background as a coach, health coach, and social worker, anything else that you want to add that might be helpful or that we haven't talked about?
Um, I think that I think it's easy for us to get so busy. This isn't against us or any provider, actually, medical or just any provider. The workload is so overwhelming that we just sort of put our head down and keep working with people. Again, I think PTs are great to build relationships, and I think mostly create safe spaces for our patients. Um, I think the more that we do collaborate with other providers, other and varying providers, um, so that we can have conversations about patients with them and really collaborate and provide um, a, a holistic um, care team for our patients, and maybe even start to change our communities so that even just the people in the communities see that um, mental and physical health come together or go along hand in hand, and we don't need to be afraid of either one, just to uh, collaborate and communicate with each other, which is hard enough, and really support the patients.
Yes, I 100% agree. That's very, very important. Um, and now jumping to the final questions. What is your favorite resource of information?
Um, I uh, well, as far as PT education for patients, I really like Adriaan Louw and Lorimer Moseley, um, because they really understand the fear piece and then how to present information to patients in a way that's understandable, but also really recognizes the holistic um, sources of pain and how we can be misguided with that. Also, Stephen Porges is a researcher and author of the book The Body Keeps the Score. That's a great book about the polyvagal theory that Dr. Porges came up with. And he does a nice job, I think, of explaining that and helping us to see just how when someone has pain and isn't really compliant, we call it, they're more ambivalent, uh, then we can have a different kind of conversation with them. It's that's the other thing about motivational interviewing, is that we are all ambivalent about something. We're kind of, our values conflict with each other. And so understanding how normal that is, and then helping our patients talk through that.
Yeah. I heard about that book before. Another guest already mentioned. I don't recall which one, but I remember the name.
It's a great book. Yes, it's good reading for all of us.
Awesome. And what would be the best advice you give to the clinicians that are starting their careers?
People are just starting their careers, then I want you to know that it takes a full year just to start to understand and really feel like you are competent. So give yourself that full year and learn from everyone and really educate yourselves. Um, well, this isn't just for them. We all need to continue to learn and grow and expand our horizons and our understanding and be open to things that are uncomfortable for us.
Yes. And what personal qualities or abilities that you think are important to become a successful physical therapist?
Hmm. I think that a willingness to be humble and teachable, like so that we don't have to be the expert. In fact, it's better if we're not. So, a willingness to be humble and vulnerable and listen and learn and um, not afraid to try things and just really be a good listener um, to patients and to each other. More a lot of qualities, really. um, Attempting to understand another person's point of view um, and just that willingness to not. Um, I think a lot of PTs are well educated and very intelligent, and sometimes our intelligence gets in the way of just setting that aside and just being open to what's going on around us, the other cues.
Yes, very true. And Janet, for people that want to learn more about you or contact you, how they can find you?
Um, they can go to my website, although actually it's a pretty bare bones website, but that is delongwellness.com. So don't have high expectations, but you can contact me that way.
Awesome. Uh, Janet, I appreciate so much you taking the time to share your knowledge with us, all your experience, all these years, your different backgrounds. So that was very insightful, helpful, and I'm sure that we are going to be helping many PTs on this challenge of treating persistent pain in these challenging patients that I know you like. So thank you so much.
Oh, thank you, Mariana. I really appreciate you inviting me on here. And actually, kudos to you for helping so many PTs. So you end up helping so many people through your podcasts. So thank you for that.
Thank you. I appreciate it. Bye bye.
Bye bye.